Welcome to the Deep Dive. Today, we're really getting into a core topic for pediatric nursing, the growth and development of adolescence, covering those critical years from 11 up to 20.
It's a huge one. I mean, this whole transition going from being a kid totally dependent on parents to, well, an independent young adult, it's massive. Only infancy sees more change, really.
Exactly. And our mission for you listening is to cut right to the chase on this foundational chapter. We want you to pull out the essentials, the physiology, those key psychosocial theories, Erikson, Piaget, Kohlberg, and crucially, the nursing priorities you've got to master.
That's the goal. We need to sort of weave together how the physical changes fuel the psychological ones. And ultimately, it's about the nurse's main job here, promoting health and, frankly, tackling those high-risk behaviors, drugs, recklessness, violence that unfortunately spike during this time because of these developmental shifts.
Okay, let's unpack this, starting with the biological blueprint.
Yeah.
Puberty, that rapid transformation.
Right, puberty. It's basically a cascade. Starts with signals, environmental and from the central nervous system, telling the hypothalamus to release GnRH. That gets the pituitary going, releasing FSH and LH.
Okay.
And those hormones act on the gonads, triggering the production of estrogen and testosterone. These are the hormones that literally reshape everything: muscles, bones, skin, even the nervous system. It's pretty dramatic.
And the timing difference between boys and girls, that's key for nurses to anticipate things, isn't it?
Absolutely crucial. Girls usually start earlier, maybe around 9 or 10. Boys are typically a bit later, closer to 10 or 11.
And for girls, the first sign.
The first thing we usually see is the thelarche that's breastfeeding, typically between 9 and 11. Knowing the sequence is important clinically. Pubic hair growth comes next, and then menarche, the first menstrual period.
Right.
The average age for menarche is about 12.8 years, but, the normal range is pretty wide. Anywhere from 9 to 15 is considered typical.
So knowing that order helps gauge if development's on track. And for boys, what's the first sign nurses should look for?
For boys, it starts with testicular enlargement. That marks Tanner stage 2. And this is really important for anticipatory guidance. Later on, they'll experience their first ejaculation.
Oh, okay.
Nurses absolutely need to normalize things like nocturnal emissions or wet dreams. Make it clear it's normal physiology, not something to be ashamed or confused about.
You mentioned the sheer speed of growth earlier. This adolescent growth spurt is huge, second only to infancy, right? And it heats at different times, too.
It really does. For girls, their big height spurt actually happens before menarche.
Yeah.
And it usually stops about 2.5 years after their first period.
That's interesting.
Boys start their spurt later, maybe between 10.5 and 16, but their growth involves more muscle mass increase, and they end up with greater cardiovascular and respiratory capacity. Bigger lungs, bigger chest, more blood volume than girls.
And beyond just getting taller and stronger, what other systems are maturing?
Well, the brain keeps developing, not growing much bigger, but the neural processing gets faster because of myelination. The basal metabolic rate kind of settles into adult levels.
But the really obvious changes. Skin. Androgens ramp up sebum production. Hello, acne. And those apocrine sweat glands kick into high gear, causing body odor.
Yeah, and those visible things, acne, BO, they hit right at the core of body image and self-consciousness, don't they?
Right,
Which
yeah.
leads us right into...
Exactly. It's a perfect bridge. Trying to manage pimples and sweat while your brain is also doing gymnastics. It's a lot.
Here's where it gets really interesting. The cognitive and psychosocial shifts. Let's get into those frameworks.
So Erikson calls this stage the big battle. Identity versus role confusion. The adolescent is basically trying on different hats, experimenting with roles, behaviors, figuring out who am I, where do I fit? And what's interesting is they often kind of revisit earlier challenges, trust, autonomy, industry, but now in this new context, redefining their place in the world. Success kind of depends on how well they navigated those earlier stages, too.
And it's not like they figure it all out at once. It happens in phases, doesn't it? Definitely phased. Early adolescence, say 10 to 13, is all about fitting in with peers. Intense conformity. They're also starting that sometimes awkward push for independence from parents.
Right.
Middle adolescence, maybe 14 to 16, that's peak time. The need for peer acceptance is highest. Conflict with parents often peaks too. And they're really actively trying out different roles, different identities.
And then later on.
By late adolescence, 17 to 20, things tend to settle a bit. We usually see a more secure body image, a clearer sexual identity. They're almost emancipated from parents. And more realistic, though often still idealistic, career goals start to form.
That idea of gaining clarity, it connects perfectly to Piaget's formal operational period.
Yeah.
Moving from just concrete thinking to being able to think abstractly, that's a huge leap.
It's massive. But there's a tricky part in the early phases of this abstract thinking: intense egocentric thinking. They genuinely believe everyone is watching them, analyzing them, the imaginary audience idea.
Right, like they're always on stage.
Exactly. And this feeds into feeling totally unique, special, and ultimately omnipotent. Like nothing bad can possibly happen to them.
And that feeling, that sense of being untouchable, that's the mental barrier nurses are up against when teaching safety, isn't it?
Yeah.
Because if you think you're invincible.
Precisely. It directly fuels risk-taking. Why worry about consequences if you feel omnipotent? Thankfully, this usually matures. Their thinking becomes more logical, organized, consistent over time. That's what allows for real critical thinking and setting achievable goals later on.
And having that abstract thinking ability is also what lets them move into Kohlberg's final stage of moral development, right?
Yes, the post-conventional moral development level. They shift from just following rules set by family or society because they're rules to developing their own internal moral compass. It's based on deeper concepts like rights, values, universal principles. But you need that abstract thought Piaget described to even get there.
So if they're building their own moral code based on principles Kohlberg, that's naturally going to cause some friction when they start questioning, maybe rejecting, rules set by parents that now seem kind of arbitrary to them. Let's talk about the family dynamic. That striving for independence inevitably causes family disequilibrium, right?
Oh, absolutely. It creates a lot of stress, often for everyone involved. The key advice for parents, the stuff nurses need to share, is finding that balance. You can't be overly strict, clamp down on everything, but you also can't just drop all rules and guidance. It's tough.
So communication is key.
Communication is everything. The advice, like what's outlined in box 7.1 in the text, is practical. Talk to them, not at them, like equals. Pay attention to your own body language, your tone. Set rules collaboratively and fairly if possible. And maybe most importantly, don't forget praise and approval. They still need it, maybe more than ever.
Okay, so as things get maybe a bit tense at home, their focus shifts outwards. The importance of peers just skyrockets.
It becomes paramount. Peers offer companionship, loyalty, someone to talk to about family stuff, and they're absolutely central to figuring out that identity piece we talked about. Figure 7.4 in the chapter really illustrates this shift.
And peers are powerful role models.
Incredibly powerful. Sometimes for the good, pushing towards college positive activities, but also sometimes negatively influencing things like alcohol use, maybe gangs, other risky behaviors.
Which brings us to another big part of identity exploration. Sexuality and dating.
Yeah, adolescence is the critical time for developing sexuality, that whole complex mix of thoughts, feeling, behaviors related to who they are sexually. Experimentation is really common. It's part of sorting out their identity and doesn't necessarily define their long-term orientation.
And the chapter highlights the increased health risks for sexual minoritized adolescents.
It does, and it's critical nurses are aware. They face significantly higher risks for things like depression, suicide, substance use, even victimization. The evidence, like in EBP 7.1, clearly shows that personal acceptance, family acceptance, societal acceptance, these are hugely protective factors. Schools and nurses can play a massive role here.
Okay. And what about dating trends?
Well, it's interesting. The percentage who date frequently does go up with age, as you'd expect, but it's also true that a lot of teens, even in late high school, say they've never dated. When dating happens in a healthy way, it's great for building self-identity and learning crucial interpersonal skills like empathy. But unhealthy dating relationships, they're linked to poorer school performance, depression, and unfortunately, dating violence.
And we should briefly mention culture and socioeconomic status, too.
Definitely. Trying to fit in with peers can sometimes clash directly with family cultural norms or expectations and socioeconomic status. It's a major barrier. Lower SES consistently correlates with more physical and psychological health problems and often higher rates of risk-taking.
Okay, we've covered a lot of the developmental leaps, the mental, the physical, the social, but now we need to shift gears. For the nursing student listening, for clinical practice, the #1 priority, hands down, has to be safety. The leading causes of death for this age group are just stark. What's #1?
Unintentional injuries, by far. Followed by poisoning, which sadly often involves opioids now, and tragically, males are at a much higher risk for injury death overall.
And within unintentional injuries, the biggest single killer is still motor vehicle accidents, right?
So the leading cause of injury death, yes. And the reasons tie right back to what we discussed with cognitive development. inexperience behind the wheel, impulsivity, huge peer pressure effects, especially with other teens in the car, and simply not using seatbelts often enough.
So, interventions.
This is where things like graduated driving license, GDL programs, are so important. They work. Restricting night driving, limiting passengers. These things demonstrably reduce crashes for new teen drivers.
Beyond cars, what other key safety teaching points, like from Teaching Guidelines 7.1, do nurses need to hit hard?
Firearm safety is absolutely critical. Teaching safe storage guns locked, ammo stored separately. Water safety too, because drowning deaths in this age group are often linked to that risk-taking impulsivity near water. And with sports being so common, promoting proper safety gear to reduce concussion risk is vital.
All right, let's switch to nutrition, which is complicated by that rapid growth spurt, but also teenager food choices.
Right. Their nutritional needs shoot up more calories. Zinc, calcium, iron are really key. Adolescent girls need about 15 milligrams of iron daily, for example. Box 7.3 gives good food source examples. And this is happening against the backdrop of the obesity crisis. The rate for 12 to 19-year-olds has more than tripled in 30 years. It's now over 20% prevalence.
Wow. And the drivers are what you'd expect.
Pretty much. Poor food choices, lack of exercise, too much fast food, and way too much sedentary screen time.
So nursing interventions focus on those lifestyle factors.
Exactly. You assess their actual diet preferences first. What do they like? Then you promote things like healthy breakfasts, really push for that 60 minutes of physical activity every day, counsel about reducing screen time, and use tools like the MyPlate plan to get them involved in making better choices. Sometimes you might even use a nursing diagnosis like ineffective adolescent eating dynamics.
Okay, finally, we have to address the really tough developmental concerns. Violence, suicide, and substance use. These are heavy hitters.
They are incredibly serious. The mental health picture is alarming. Suicide is the second leading cause of death for young people aged 10 to 24. And get this, 16%, 1/6 of adolescents reported seriously considering suicide in the past year.
That's devastating.
It is. Nurses have to be incredibly vigilant for risk factors: depression, any prior attempt, substance abuse, identifying as LGBTQ plus lack of support. Box 7.6 lists many critical ones.
And violent.
Homicide is the third leading cause of death overall, but it's the #1 cause of death for African American youth aged 10 to 24. Firearms are a huge factor, as is gang involvement. Box 7.7 details some risk factors for joining gangs.
And substance use, still a major concern.
Always. Alcohol and nicotine, mostly cigarettes historically, are the most accessible. But the really big clinical update everyone needs to know is the dramatic recent spike in e-cigarette and vaping use.
Right, that came up fast.
It jumped 78% among high schoolers just between 2017 and 2018. And nicotine in any form is highly addictive and genuinely harmful to the still developing adolescent brain. Illicit drug use overall is actually at relatively low levels, but marijuana remains the most widely used illicit substance.
So with substance use being so widespread, or at least the risk being high, how should nurses approach interventions?
Well, assessment is key, especially during vulnerable times, big life changes like moving, parents divorcing. That's when risk can increase. Programs need to be culturally competent, focusing on awareness of risks, sure, but maybe even more importantly, building up protective factors.
Like what?
Things like strong connections with parents and family, feeling connected to school, involvement in positive activities like religion or sports, and explicitly teaching stress-specific coping skills. Those seem to make a real difference.
Okay, let's try to pull this all together.
If you synthesize this whole chapter, you basically see adolescence as this period defined by the search for identity, that huge cognitive leap to abstract thought, which, paradoxically, brings that dangerous feeling of invincibility and these really intense, fluctuating relationships with peers and family.
So the nurse's role, it's really about being that expert guide through one of the most unpredictable but also vital periods of human development, providing that non-judgmental guidance, anticipating the risks based on where they are developmentally, and working with the teen and their family. So what does this all mean? The core knowledge is now distilled. The nurse must be the expert guide, equipped to navigate the dramatic physical and mental shifts while proactively shielding the adolescent from the inherent risks of this developmental stage.
And maybe a final thought to leave you with. Considering those high rates of mental health issues, suicide, violence we talked about, How could nursing interventions that really focus on strengthening school connectedness, fostering supportive and inclusive environments, particularly for vulnerable groups, like mentioned in EBP 7.1, how might that radically improve long-term health outcomes for this generation?
That's a powerful question for every current and future healthcare provider working with adolescents. Thank you for joining us on this deep dive. Now go apply this knowledge.